Dr. Ziad Kazi is an emergency physician and an associate professor at Emory University. And his talk will be about the impact of medical toxicology on global health. Dr. Kazi.
Thank you. Thank you. I'm in good shape. I only have 45 slides, so we should be okay. Thank you so much for inviting me. This is my time to pitch to you that medical toxicologists like myself can have a role in global health. I'm currently at Emory University in emergency medicine. I'm also the director of the International Postdoctoral Fellowship in Medical Toxicology at Emory. Additional affiliations include I'm a secretary and co-founder of the Middle East North Africa Toxicology Association. I'm a board member of the American College of Medical Toxicology and the chair of the International Committee, and I'm the assistant medical director for the Georgia Poison Center. My message to you is clear. Medical toxicologists and the medical toxicology specialty can play a role and have a positive impact on global health. And the message is specifically through prevention, through clinical care, and education. My colleagues have talked about non-communicable diseases, did not mention toxicology and poisonings. Poisonings also around the world cause death and morbidity. The WHO in 2004 reported 346,000 deaths from unintentional poisonings, 91% of which occurred in low and middle income countries. Suicide takes a million deaths around the world, a third of which are from pesticides. Snake bites also are common around the world, with 5 million bites reported by WHO and associated mortality and morbidity. Poisonings also occur in outbreaks and epidemics. Methanol, diethylene glycol, lead are all usual culprits. Lead recently in Nigeria through the improper processing of lead-containing ores to extract gold in villages in Nigeria led to over 400 deaths in children less than 5 years of age. Methyl mercury in Iraq and in Japan, and radioiodine release from the Chernobyl nuclear power plant accident in 1986. Unfortunately, poisoning has an asymmetric burden on low and middle income countries. This is because these countries have poor access to care, poor access to antidotes and other resources, lack of specialized workforce, lack of policies to protect the public, and lack of data systems that will help us analyze the situation and come up with response plans and mitigation plans. Medical toxicology is a specialty currently in the US that's approved by the American Board of Medical Specialties that focuses on the diagnosis, management, and prevention of poisonings from medications, chemicals, occupational environmental toxins, and biological hazards. Currently in the United States, medical toxicologists are physicians, primarily from emergency medicine, as well as pediatrics and preventive medicine. However, we also have some colleagues who are trained in medical toxicology who come from internal medicine, psychiatry, neurology, and a few other specialties. We are board certified since 1993. We have a core curriculum. We have residency training around the US. We practice at various settings: inpatient, outpatient, academic, private practice, research, government, industry, global health, legal consulting, and telehealth. We also have a broad scope of practice from environmental, occupational, intentional overdoses, envenomations, terrorism preparedness and response, ionizing radiation, addiction medicine, forensic and analytical toxicology. We offer solutions to the global health burden of disease through poisoning. We offer it through prevention. We aim at preventing exposures to chemicals. This is through poison control centers, through consulting, assessing and characterizing circumstances and sources of exposure to the public. Once we understand that, we can raise awareness and influence public policies. We've done that in the US successfully with lead. We were able to drop the hazardous lead levels in our population over the years through a series of campaigns, public awareness campaigns, and governmental policy changes. We can do it around the world as well. Through clinical care, we can offer our expertise and assistance through telemedicine. We at Emory have recently started to offer this telemedicine toxicology support to the American University of Beirut. I am currently on call, so I hope they don't page me in these precious 7 minutes that I have left. We also offer support in outbreak response. Our fellowship in medical toxicology at Emory is affiliated with the Centers for Disease Control and Prevention, as well as the Georgia Poison Center. We participate regularly in any epidemic or outbreak that comes to the CDC. These are my fellows at various locations around the world investigating unknown chemical exposures or illnesses. We offer solutions through education. The Middle East North Africa Toxicology Association is the only clinical toxicology association in the Middle East and North Africa. We are holding our annual training programs. We also offer in-country training programs through our activities in India, as well as other countries in the Middle East. Finally, we also try to reach people through technology, webinars, and satellite broadcasts around the world. In summary, medical toxicologists can play a role globally, and we do that best through prevention of poisonings. We also do that through educating the workforce and also by providing clinical care through telemedicine. If you'd like a copy of my slides, you can email me at the zkazi@emory.edu, and I thank you for your attention. And I'm early.
So thank you, Dr. Kazi. While we're getting the slides ready for the next speaker, I just want to introduce Dr. Jeremy Ackerman. He's a physician, inventor, and engineer. He teaches undergraduate and graduate courses in engineering design and healthcare for the Georgia Institute of Technology, and he's also an attending emergency physician at Emory University. And his talk will be called Towards Being Ready to Innovate, Bridging the Gaps Between Technologists and Clinicians. Okay, welcome, Dr. Ackerman.
Thank you. So it's a pleasure to be standing here in front of everybody. Today I want to talk about a problem that I've been aware of for some time and which has sort of motivated my whole career, and I'm just now realizing that I need to be telling people about the problem as well as what I've been working on developing to help people with it. So fundamentally, the problem that we face right now in developing innovation in healthcare is that physicians, as a general rule, are not ready to innovate. And the engineers and scientists and computer scientists and all those folks that we need to help drive innovation in healthcare are not prepared to innovate within the healthcare space. So this was me back in 1995, except not the guy in the white coat, the one with the pants down, except I was a junior in engineering at Washington University in St. Louis, and I found myself sitting in my doctor's office staring at this picture. Okay, for those that don't know, this is a picture by Norman Rockwell that was on the cover of the Saturday Evening Post in 1958. And it occurred to me while I was sitting there, coming from my dorm room where I had all sorts of new gizmos and gadgets and cool technology that I was learning how to build, sitting there in my doctor's office, basically the scene hadn't changed since 1958. And it occurred to me that there was something wrong with this picture, that there had been no evolution in approximately 40 years, or at least nothing that you could outwardly see. And that's when I turned around and said, you know what, I'm going to finish my engineering degree, but I want to be able to have an impact in this space. I want to get the new innovations there. And at the time, the way that I saw for me personally to do that was to go to medical school. So I've been to medical school, I did a PhD in biomedical engineering, and this is the direction that has worked very well for me personally, but it's not really a workable way to get the large number of people that we need in the innovation space in healthcare ready to innovate. There's a big challenge here because people who do innovation have a peculiar way of thinking about what it takes to do an innovation, to make money off of it, which is a big driver to what we do. And so classically, when you go to places where people are learning about how to innovate, how to do startups, how to drive new technologies, this is the Venn diagram that you see. What's desirable to my users? What's possible with the technology? And what's viable in the marketplace? We as clinicians may have a good idea about what's desirable to users, but we frequently don't really know what's possible with the technology, and we almost definitely don't know what's possible and viable within the marketplace, which means that we end up with ideas that are somewhere up over here, which is not where you get to innovations that go anywhere. Okay, you need to be in the center. The problem for the engineers is that within healthcare, in order to get to a product that's workable, there's a whole different Venn diagram of understanding what the actual problems are. You have a vast array of different people, doctors, nurses, techs of various kinds, patients, who all have to be able to work with whatever your innovation, device, or idea is. You have very different physical environments that these things have to be used in. You have a set of devices and other tools that are already in place. And then you have these horrific and very large healthcare systems that you somehow have to integrate your idea into. As clinicians, we sometimes understand that, although frequently we see the patient in front of us very, very well and often lose sight of everything else that you need to understand to be able to innovate well. So there is a known solution about how to bridge this gap, and lots of other industries do this fairly well. And within the healthcare domains, lots of people make efforts. The key is that you have to take the people who you want to have do your innovation and you have to get them into the clinical environments. They have to be able to shadow, watch what the doctors, nurses, patients are doing, and generate that larger understanding. So how do most people do it? What they tend to do is they tend to say, well, I need a doctor who's interested in solving a problem, and they take an engineer or a group of engineer or trainee, and they have a fairly brief, small group or one-to-one mentoring process. And what happens is the clinicians say, on Wednesday, you can come in when I'm doing some procedures you'd be interested in. Or I'll meet with you an hour next week and the week after. And it's simply not enough time, and it's not a broad enough view of what's going on. The other problem is when you do that, the clinicians tend to drive the understanding of the problem. And as I said, for big problems, the clinicians are very good at telling you about the patient in front of you, but often lose sight of the larger picture of the problems and lack the understanding of how all this integrates with a system. And then the clinician's time tends to be highly constrained due to cost. There's also a huge problem of not really easily generating enough clinicians or clinical sites. There are lots of rules and regulations. And you'll notice I say HIPAA and OSHA, those are real barriers to bringing non-clinicians into clinical settings, but there are an awful lot of things that are merely matters of perception. Oh, I am not allowed to have a student here. Is there a rule? Is there a law? Often there's not. It's usually just the clinicians, the administrators that you need to convince to do it don't believe that things like this is possible. The students often are forced in who they get to shadow and are often told what's important, which does not get to having a good understanding of what the problems. And finally, there's always this question, is doing something like this allowed? I take a very different approach. I teach a course with Georgia Tech where I've had from 20 to 60 students at a time, where we bring them in for lectures where we teach them how to behave in a clinical setting. And then we simply put them in a clinical setting. It's our active emergency departments. They wear uniforms, these nice light blue lab coats, where they run around and they watch whoever they can. They find doctors and nurses who are interested and exciting about telling them the problems they're facing. They have the opportunity to talk to patients. And then they come back to the classroom and work with me and sometimes others of my colleagues and get a broader understanding of the problems that they've identified firsthand. Over the course of the semester, they identify 4 problems. The big question is, how do we do more of this? I'm one guy with one site. We've done this in 3 different healthcare systems now, but it's challenging. When you work with a single clinician, you can ask that clinician to volunteer a little bit of time. When you teach a class semester after semester, it's a big amount of time. In the long run, it's probably much less expensive than trying to recruit new clinicians time and time again. And what we really need to do is identify other places, other clinicians who are excited about teaching our future innovators how to innovate and have them create a similar program in other settings. Lots of folks have supported my work. Much of my time has been paid for with endowments from the Wallace H. Coulter Foundation that's been very motivated to help develop our medical healthcare innovators of the future. There are a couple of medical schools that have models where they'll have medical students work with engineering students. It's a good start. The challenge is those medical students don't know the clinical world well enough to actually guide the engineering students through. The engineering students, I think, are providing much more of a service for the medical students than the other way around. But there's definitely a need to get more clinicians to think about this, to understand that their ideas are important, can change practice. The other challenge in working with clinicians is we're trained to believe that we're right most of the time. And there's a tendency when we work with other people to push things the direction that we understand rather than listening to what might be better solutions. Thanks.
Thank you so much, Dr. Ackerman. Our next speaker is Professor Junaid Razak. Dr. Razak is currently a full professor in emergency medicine and senior advisor in global health at Johns Hopkins School of Medicine. Prior to joining Johns Hopkins, he was the founding CEO of a not-for-profit organization, the Aman Healthcare Services in Karachi. He's worked at Yale University and Emory University and is now at Johns Hopkins. His talk today will be Success and Challenges of Healthcare System Development, Lessons from Karachi, Pakistan. Thank you very much.
Thank you, first of all, to the organizers for inviting me. It's been a great privilege to be back in a city where I used to work many, many years ago. What I wanted to share with the group today is my experience going from a clinician to a clinical leader in Karachi to then getting an opportunity of setting up a social impact organization, which we feel rapidly grew, and now coming back to the academia and seeing how things have evolved and changed in the US over the past 10 years. I'll start with this real-life interaction that I had with the father of a young child, a 9-year-old in Karachi, who left his home on a Sunday afternoon, it was a holiday, to bike outside his house. And while he was bicycling with his cousin, an unfortunate event happened. He was hit by a large truck, was on the floor, on the road for several minutes, about 20 minutes, was taken to a first hospital, a close-by hospital, which was not ready to see the trauma patient that he was. About 45 minutes later, he was shifted to another hospital, which is about 2 miles down the road. It's a trauma center. He was intubated, a tube was passed on his airway. And during that time, the family got there and they took him to the hospital I used to work at. And I saw this child who had a tube in his throat, was paralyzed in another hospital, but unfortunately the tube was in the wrong place. And the child was being brought by the father, who was obviously very, very upset. And when I spoke to him that his child had been dead probably 45 minutes ago, an hour ago, he said, among other things, that for many years now he has not woken up without the first thing he sees is the face of his child. And he says there will never be a morning again. And many things, this is a story that's happening several times a day in many of these cities. In Karachi, this is a big place. It's the second largest city in the world. Thousands of doctors and physicians, nurses available all over the place. But things do go wrong. And what went wrong here? It's a child safety issue. We all talk about it. It's a care and decision at the scene. It's a transport to the wrong hospital. It's the next hospital, a poor quality of care. Who is taking these patients, sick patients, to these hospitals? And that's a story, that motivated a lot of us to do other things and see if you can come up with a system solution. We cannot just train people and expect things to change. There is a lot more complexity around it. So this is Karachi, 23 million people now. In 2011, there was a bomb blast every 4th day in the city of Karachi. And the system still worked. People were moving around. Another story, and that story led to a big change. A professor of medicine, a health secretary, was shot and was taken to a hospital, largest trauma center, but they couldn't get into the emergency department in time. He was taken to another hospital, was seen by the top surgeons, was operated upon, woke up 3 days later, unable to move, neck down, and somebody missed a C-spine injury, and there was a big discussion. And several years later, the family of that physician came back and they said, we would like to fix the emergency healthcare and the larger healthcare system in the city of Karachi, and donated a large amount of money. And I became sort of part of it. And over the last 5 years, what we've been able to do was to establish a large healthcare system that takes care of emergency care through an ambulance program that has transported over now 600,000 patients in the past 5 years. Paramedic training program that has trained over 15,000 people. There is a primary care program that's serving about 1 million people a year. A telehealth program with almost 1,000 calls a day, and a focus on the training on the secondary care. So a lot of this was possible in a very short time of 5 years. And I think that the reason it was possible was because it's such a vacuum, there's such a need. And if the resources are available, you can do a lot more in those communities. But two things I want to talk about is building systems is relatively simple. That's my perspective. As a clinician, as a person who built those systems, I think we could do that. Big challenge is human resources. Even that is solvable because you have large number of very smart people in these communities. The difficult part is healthcare financing. And we all talk about providing care to the poor, especially urban poor, and using social business model. But then there's a large number of people who are so poor that they can't pay anything, and that's where the dilemma for emergency care is, because we can't refuse care to anybody. And then the coming up with research and writing about and sharing those ideas and learnings is very important. Very quickly, we talked about EMS, the telehealth system, the community health program that is now funded through the Gates Foundation, Packard Foundation. And then this is my other life on the clinical side, the university and the big department. Last two slides, I just want to say that there's a huge need, of course, for healthcare system improvement. There's a big space for innovation, and rapid success is possible. Quality is a big challenge. A lot of us who work in these settings would do things that we would not do in the US, for example. The quality of care, we will accept the lower level of quality of care, which I have a huge issue with. But I think the bigger problem is sustainability. And the question is, the bottom of the pyramid paying for the service, and while some can, many people at the bottom of the pyramid cannot pay for those services. And what do we do with that? I think there are ideas around government subsidy. A lot of places, now in Asia, for example, South Asia, governments have money, India, Pakistan, Bangladesh. It's a problem of finding the right priorities. There's a lot of discussion on fee-for-service. There's a discussion on philanthropy. The solution for the bottom of the pyramid is actually a combination of the three. And we have not yet figured out what the right combination is. But I think for individual problems that we see, I feel we have to find a combination that will give uniform access to life-saving emergency care. Thank you so much. I'll stop here.
And thanks for coming so far to give an interesting talk once again. Our next speaker is Professor Lisa Marino Walton. Professor Walton is the Clinical Emergency Medicine Director of Research and Director of Diversity, Director of HIV Testing at Louisiana State University. She's also a Professor of Emergency Medicine at LSU and is a member of the Board of Directors of the American Academy of Emergency Medicine. Her talk today is Optimizing Emergency Department Screening for High Prevalence Infectious Disease. So it's my pleasure to introduce Dr. Lisa Marino Walton.
Thank you so much. It is a great honor for me to be here today, and I appreciate being invited to this prestigious conference. I am going to talk to you today about a social impact project that I am involved in that is a collaboration between public and private enterprise It's been very successful at LSU, and it is very, very scalable. So some of my colleagues have talked to you a little bit about the fact that most people today globally are dying from non-infectious diseases, but HIV remains one of the only diseases communicable diseases that is still within the top 10. In fact, it's number 6. So people are dying from this at a huge, huge rate globally. HIV is an imminently preventable disease, an imminently treatable disease, and yet, epidemiologically, the communities that suffer predominantly from HIV create a perfect storm for proliferation of the disease. It is most prominent among minority populations. It is most prominently among marginalized populations who actually create a closed cohort because of their lack of ability to migrate out of the closed cohort. And so we know that when there's a closed cohort, both genetic and infectious diseases gain tremendous penetrance and gain tremendous prevalence within that cohort, causing a huge amount of morbidity and mortality and a huge economic cost as well as social cost to us as a global society. When you have a society where more than one sexual partner is acceptable culturally, either because this is implicit or because this is explicit, you create a setup where HIV will proliferate. So let's look at this. Why does this not work when we have interventions? Mostly because the interventions are not culturally competent. A physician who works in the community can actually be a participant observer in the community and can listen to the community to understand the challenges and hesitations to HIV testing. In our own community, we are a closed cohort, a small city of 500,000 people who tend not to move out of the community and mostly know each other. They do not want to be seen getting an HIV test because this will further marginalize them within their own community. So when you have identified testers, people do not want to get a test. They object to being seen being tested, and they also have minimal access to health care, so they're all going to the same place. You see, this is a map of New Orleans, and you see how concentrated HIV is. We are actually the third highest prevalence and incidence in the United States. So what kind of solutions do we have? Well, we can implement routine testing of all patients. This normalizes and routinizes HIV testing. This is what the CDC tells us that we should be doing anyway. We use a phlebotomist to do the testing model so that every patient who comes to the emergency department is being phlebotomized. There's no stigma to the patient who's getting blood drawn for an HIV test. Everybody's getting blood drawn. We don't know how many tubes of blood or what colors are going for what test, and so everybody actually gets tested. Through the emergency health record, we have an automated order for the test, so there's no stigma attached to asking people whether they want to be tested, whether they have a risk to be tested. Everybody gets tested automatically. And then we can identify acute infections because through our collaboration with the HIV Focus Program through Gilead Sciences, we're able to offer fourth-generation testing, which is an antigen antibody test. We know who is acutely infected, and we can actually, through individual counseling, infiltrate that hot sexual network where we can immediately identify contacts, recent contacts who are probably the source of the infection or recipients downstream of the infection, and we can actually intervene to stop the infectious process within the cohort. If you look at routine screening, you will see that in our program only, we have in less than 2 years tested 30,204 individual patients. Acute cases were identified 7 during year 1 and 11 during year 2. Throughout our focused partnership with Gilead Sciences, 1.65 million tests have been performed in the 10 cities in the United States where HIV is the most prevalent. So acute cases, again, some research that I did from 2011 to 2012 showed that 15% of the patients are acutely infected. These are patients who, without a fourth-generation test, would not know they were infected, but through our program, they do know they're infected. And again, we can intervene immediately to stop the downstream flow of the infection, as well as looking upstream at the source of the infection, identify and test that person, get them into treatment, and prevent them from spreading the infection downstream again. So I said this is an eminently scalable model, and it is, because it can be used and replicated for other infectious diseases such as hepatitis C, hepatitis B, and STDs. We, in fact, are doing that. 2 months ago, we started to do HCV testing of a birth cohort, and in 2 months, we've done 1,113 tests with a 19% prevalence rate. Mind you, across the focus cities, it's 8%. Ours is 19%. That shows you the power of disease transmission within a closed cohort, and we know this because this happens with Ebola, this happens with bird flu, this happens with every epidemic that we see. And so we actually have a 75% RNA positivity for all of our positive tests that are performed. And as you see, we did 364 in March with 54 positives, and 749 in April with 157 positives. So how can we reproduce this on a global scale to get to zero? So our program worked incredibly successfully in our community, and using the physician as a participant observer in the community, you can develop a culturally competent model that's acceptable to your patient population in any community in the world where there is a culturally competent testing model that gets put into place. As I've shown you, you can take this model that's successful in HIV and use it in HCV. We have, and that can be done for any epidemic disease in any country in the world. You can also go backwards when you look at cultural competence, what's important to the community, what the community cares about, what the community's values are, what the community's cultural mores are, and you can develop a prevention education program that is culturally targeted to the community in which you are working. So this is a model that shows that public-private enterprises are successful, a model that shows that you can use culturally competent interventions to increase testing, and a model that also is completely applicable to other diseases. Thank you very much.